Alright, we're going to go over Fundamentals Exam 4 study guide right now, and then we'll have one more to do after that, and then we'll go on to reviewing stuff, which is nice. Alright, tell me what perfusion is. Blood flow to cells, removing oxygen. Blood flow to cells, delivering oxygen, removing waste products. What is preload? Volume of blood in ventricles endodiastole. Think volume. What is afterload? Resistance left ventricle most overcome to circulate blood. Think pressure. What increases preload? Hypervolemia, regurgitation of cardiac valves, and heart failure. What increases afterload? Hypertension and vasoconstriction. Alright, what meds are we going to use for preload? Diuretics. What meds are we going to use for afterload? Vasodilators. What is the equation for MAP? 2 diastolic plus 1 systolic divided by 3. What should the value of MAP be? Between 70 to 100, but greater than 60. What is shock? Not getting enough blood flow, not enough oxygen, organs can't function properly, and they die. What is sepsis? Bacteria enters blood, vasodilation occurs, and fluid leaks in surrounding tissues. Decreased blood flow to organs leads to failure. What is perfusion triangle? Heart, blood, and blood vessels. What is MONA? Morphine, oxygen, nitrogen, aspirin, and you administer oxygen, aspirin, nitrogen, glycerin, and morphine. That's the order. Dope. Okay, so heart can't pump, cardiac output or stroke volume decreases, less blood reaches the organs, leading to what type of symptoms? Fatigue, lethargy, mild acidosis, increased respiratory rate. You got to back up. Congestion develops, output from the ventricle is less than inflow of blood. What are the symptoms of left-sided heart failure? Dyspnea, orthopnea, pink-tinged cough, shortness of breath, hemoptysis, and rales. What are the symptoms of right-sided heart failure? Dependent edema in feet, hepatomegaly, ascites, descending neck veins, and headache. Some facts about CHF: heart unable to pump sufficient blood for metabolic needs. It's an acute episode or chronic condition. Heart problems like wall/conduction or valve deficit. Height demand by hypertension or lung disease. One side usually fails first, followed by the other. Early stage is referred to as right or left-sided. So what's the main thing that's happening in heart failure? The heart can no longer keep up with the normal demands to pump or eject blood to the rest of the body. What is an ejection fraction the measurement of? How well your heart is pumping. What is ejection fraction used to classify? Heart failure. What's the normal value of ejection fraction? 50+% or more. Tell me about reduced blood flow. Reduced systemic and renal blood flow causes renin and aldosterone to be secreted that causes vasoconstriction or increased afterload, and increased blood volume or increased preload, and that causes increased heart workload. Then the SNS causes heart rate and peripheral resistance via vasoconstriction, decreases efficiency, filling, increased heart workload, and then you got like cardiomegaly, stuff like that. Alright, what are some of the causes of heart failure? CAD, MI, heart hypertension, faulty or damaged heart valves, cardiomegaly, myocarditis, congenital birth defects, and arrhythmias. Alright, what does the ECG or EKG measure? Non-invasive conductive activity of the heart. What does auscultation and echo do? Helps find murmurs. What does a chest x-ray do? Assess the size and shape of the heart and pulmonary congestion. What does nuclear imaging do? Valium assesses the size of infarct, myocardial perfusion, ventricle function, and tissue mass. What does a CAT scan do? Assesses cardiac ischemia at rest. What does cardiac cath do? Assesses the inside of heart. When is troponin released? MI. So angioplasty. A minimally invasive procedure to open up blocked coronary arteries, allowing blood to circulate unobstructed to the heart muscle. Alright, what do vasodilators do to the heart? Reduce workload and reduce blood pressure. What do beta blockers do to the heart? Treat hypertension and dysrhythmias. Prevent SNS from increasing heart rate. Calcium channel blockers do to the heart. Decrease cardiac contractility. What does digoxin do to the heart? treat heart failure, dysrhythmia, slows conduction of impulses in the heart rate, strengthens the force of the heart rate. What do ACE inhibitors do to the heart? Preferred treatment in hypertension and heart failure. Reduces peripheral resistance, increases preload and afterload. Diuretic due to the heart. Removes sodium and water, increase urine output, reduce blood volume and edema. Read this. Should watch a video. Let me find something. I think this might be a good thing. So, the acute heart failure, you're going to have sudden onset of dyspnea. You may have normal or elevated jugular venous pressure. You'll have frequent pulmonary rares. You'll rarely have peripheral edema. You may have weight gain, but it'll be mild if you do. You won't have cardiomegaly. You might have normal/acute abnormalities, ECGs. You might have some reversible lesions. You'll have increased BNP. Your ejection fraction will be normal, increased, or reduced. Hospital mortality depending on the cause. With chronic, you'll have exacerbated dyspnea. You'll have an elevated jugular venous pressure. You'll have frequent pulmonary rales, frequent peripheral edema. You'll definitely have frequent weight gain. You'll have frequent cardiomegaly. You'll have chronic abnormalities for the ECG. You'll have occasional lesions. You'll have increased BNP. You'll have frequently reduced ejection fraction. You might die. 5-10%. Okay, going on. So, how are we going to monitor and support adequate ventilation? We're going to record I&O, limit fluid and sodium per order, provide small frequent meals, auscultate for S3 and S4, monitor and control bleeding, and manage anxiety. How are we going to maintain adequate ventilation and perfusion? Position semi-Fowler to high Fowler and turn frequently. Administer oxygen as prescribed. Administer blood and meds and diuretics as ordered. Monitor O2 sats and then schedule nursing care to provide rest and minimize fatigue. Okay. So I'm going to teach the patients to stop smoking, get a better diet, lifestyle, and exercise regimen, follow meds. What are the heart failure risk factors identified by the CDC? CAD, MI, diabetes, high blood pressure, obesity, valvular heart disease. So what are some things that affect our heart rate? Activity, caffeine, nicotine, other meds, hypertension, and stress. Tell me about normal sinus rhythm. PR interval is usually 0.12 to 0.2, and constant QRS is 0.04 to 0.1, and constant 1 P wave. Read these. Asystole, check the leads, then stay PR, then code. Brain will die in 3 to 5 minutes. Read this. Okay. What's the pH of acidosis? Less than 7.35. What's the pH of alkalosis? Greater than 7.45. All right. What is acid production? Generation of acid via cellular metabolism. What is acid buffering? Process to control changes in pH by neutralizing acids with buffers. What is acid excretion? Removal of acid from the body. What acid did the lung excrete? Carbonic acid. What acid does the kidneys excrete? Metabolic acid. Alright, what are some risk factors for disorders that cause acid-base imbalance? Kidney disease would be metabolic acidosis. Then you got lung problems, CO2 retaining diseases such as asthma, COPD, and emphysema. Respiratory acidosis. Diabetes is metabolic acidosis. Excess bicarb intake is metabolic alkalosis. Vomiting is metabolic alkalosis. And burns are metabolic acidosis. Alright, what is acidosis? Too much acid or not enough base. What is respiratory acidosis? Containing too much CO2. What is metabolic acidosis? Lose too much HCO3 or hold on to too much hydrogen. What is alkalosis? Too much acid or too much base. What is respiratory alkalosis? Losing too much CO2. Hyperventilation. What is metabolic acidosis? Too much HCO3 or losing too much hydrogen via the kidneys. What usually causes acid-base imbalance? Underlying conditions. It's not normal, but it's expected. If a chronic complication is present. Alright. Alright, let's say you have too much carbonic acid, so respiratory acidosis. What is the respiratory response? Hypoventilation is causing this, so you're going to correct this via hyperventilation. What will the kidneys do? Compensate by increasing hydrogen secretion and producing more NH3. Let's say you have too little carbonic acid, so like respiratory alkalosis. What's the respiratory response? So, the cause of the respiratory alkalosis is hyperventilation, so we'll correct this by hypoventilating. What will the kidneys do? Decrease hydrogen secretion and produce less NH3. Say you have too much metabolic acid, so metabolic acidosis. What will the kidneys do? So, what's causing the metabolic acidosis? Too much metabolic acid is being produced, then can be excreted. So, we'll correct this by having the kidneys increase secretion of hydrogen and making more NH3. What will the lungs do? They will start hyperventilating. What if you have too little metabolic acid, so like metabolic alkalosis? What will the kidneys do? So you have, the cause of this is too much HCO bicarb and the kidneys can excrete. You have too little metabolic acid. So we'll correct this by decreasing secretion of hydrogen and less NH3 production. What will the lungs do? Start hypoventilating, breathing slowly. Alright. Can you delegate ABGs? Nope. Who most often performs these? Respiratory therapist. What do you got to do before you can do the ABG? Allen test. Alright, what's the normal value of pH? 7.35 to 7.45. What's the normal value of PaCO2? 35 to 45. What's the normal value of HCO3? 22 to 26. Alright. What's the pH? What are the values of respiratory acidosis? pH is less than 7.35 and PaCO2 is greater than 45. What causes respiratory acidosis? Obstruction of gas exchange or hypoventilation, so too much carbonic acid, so like emphysema, chronic bronchitis, severe pneumonia, pulmonary edema, asthma, apnea, narcotics, illegal drugs, Islamic sleeping meds. What are the clinical signs of respiratory acidosis? Headache, restlessness, confusion, dyspnea, respiratory distress, shallow respiration, tachycardia, dysrhythmias. So like this can also happen to people whose bag does not fully inflate with the CO2 rebreather. What are the values of metabolic acidosis? pH less than 7.35, HCO3 less than 22. What causes metabolic acidosis? Not enough HCO3 in the blood or too much acid, so shock, DKA, renal failure, diarrhea, diuretics, and certain drugs. What are the clinical signs of metabolic acidosis? Decreased LOC, abdominal pain, hyperkalemia, dysrhythmias, and compensatory hyperventilation. What are the values of respiratory alkalosis? pH greater than 7.45, PaCO2 less than 35. What are the causes of respiratory alkalosis? Hyperventilation, so acute respiratory alkalosis could be like pain, fear, and anxiety, and chronic respiratory alkalosis like hypoxemia from pulmonary disease, hypermetabolic states like a fever, cirrhosis, and gram-negative sepsis. What are the clinical symptoms of respiratory alkalosis? Increased respirations, dizziness, confusion, tingling of extremities, lethargy, coma, dysrhythmias, and hypokalemia. All right, what are the values of metabolic alkalosis? pH greater than 7.45, HCO3 greater than 26. What are the causes of metabolic alkalosis? Excess base or decreased acid in the blood. So like antacids, gastric suctioning, and excessive vomiting. What are the clinical signs of metabolic alkalosis? Lightheadedness, numbing and tingling in fingers and toes, muscle cramps, possible excitement and confusion followed by decreased LOC, and dysrhythmias. So for electrolyte compensation, acidosis, lots of hydrogen enter the cells, so K is kicked out. This causes hyperkalemia as H is buffered. This is sometimes called false hyperkalemia because the real underlying problem is the imbalance of hydrogen. This happens a lot with DKA patients. In alkalosis, lots of H leave the cell, so K enters, resulting in hypokalemia. All right, tell me about chemical buffering systems. They act immediately, like meds, baking soda, and bicarb directly in IV, like bicarb, phosphate, sodium, potassium, hydrogen ion exchange. What about respiratory buffering systems? They act in seconds a minute. They control the respiratory rate. Blood pH changes according to how much H2CO3 is present. So the body uses respiratory buffering even when there's a metabolic problem, because the respiratory system can control how much carbonic acid the body has, even though it can control the amount of metabolic acid, even though it can't. Tell me about the renal buffering system. It takes hours or days. So when pH is low, kidneys hold on to HCO3. When pH is high, kidneys eliminate it. Compensation short term. Tell me about anion gap. Which one does it deal with? Metabolic acidosis. So it tells us where the metabolic acids are coming from. So normal ratio of the anion gap. 3 to 12, and it's 17 plus, it's a high anion gap. All right. What causes metabolic acidosis with a normal anion gap? HCl, so it's hyperkalemic acidosis. What causes hyperkalemic acidosis? Excessive loss of bicarb. What are some examples of hyperkalemic acidosis causes? Diarrhea, parenteral HCl therapy, and renal tubular acidosis. What causes metabolic acidosis with a high anion gap? Caused by increase in any metabolic acid except HCl. What are some examples of this? Ketoacidosis like DKA, starvation, alcoholism, lactic acid, circulatory shock, and extreme exercise. Excessive normal acids of renal failure, burns, severe infection, and methanol poisoning, ethyl glycol poisoning. All right. And take a minute to read these slowly. Get these down, bad boy.